syndrome. So the genetics involve the Menin gene. So this is basically in chromosome 11q13. This was first described in 1997. So this describes a nuclear protein which is known as Menin. So the Menin gene actually has a host of functions. It is a transcription activator, transmission repressor. It is involved in cell signaling proteins. It is involved in as a co-receptor with other proteins. So it has got a multitude of proteins, and in the endocrine organs or in the endocrine tissues, the Menin functions as a tumor suppressor gene. Now, it is not only involved in the endocrine tissue, it is also involved in other malignancies as well. So this Menin gene interacts with activating protein 1 transcription factor, which is known as JUND, and other proteins, and hence this is how it plays a role in downstream transcription and cell growth regulation. So just remember, this is found in 11q13. The protein involved is Menin protein, which is a tumor suppressor protein in endocrine tissues, and basically this has multiple actions, and it acts by interacting with JUND protein and other proteins involved in transcription and cell growth regulation. So various mutations have been described in MEN1. The most common are Frameshift mutations. You can get missense, nonsense, and deletion mutations also. And more than 10% of germline mutations arise de novo. Almost 50% of the carriers become symptomatic by 20 years, and as I already described, almost 100% of these patients will be symptomatic by the time they reach 50 to 60 years of age. And MEN1 syndrome, that is the Menin protein, follows the classic two-hit hypothesis, where one allele is inherited through the germline mutation, and activating second hit, second deleterious mutation causes activation of the syndrome in the endocrine tissues. So again, this MEN1 mutation is not only found in Menin gene mutation is not only found in MEN1 syndrome, but it is also found associated with many other somatic mutations. So a lot of glucogonomas, VIPomas, non-functioning peanuts, gastronomas, bronchial carcinoids, parathyroid adenomas, insulinomas, adenocortical tumors. So a host of other tumors are also found to harbor these Menin gene mutations. So who should be genetically tested for MEN1? So any at-risk family member in a known kindred of MEN1, young patient less than 30 years with multi-gland or recurrent hyperparathyroidism, patients with prolactinomas, patients with multiple pancreatic neuroendocrine tumors, patients with any one MEN1 lesion along with an adrenal lesion, or patients with bronchial or thymic carcinoid. So these are the patients who require to be genetically tested with MEN1 for the MEN1 gene mutations. So usually in these patients we begin screening in adolescence. Any at-risk family member we begin screening with in adolescence, and if a mutation has been identified and that particular mutation is negative in the at-risk family member, then there is no need for any further routine biochemical screening. However, if a mutation is not detected in the proband, then again further testing for MEN1 mutation in the at-risk family member is not indicated. So let us look at this flow chart to understand this. So clinical diagnosis of MEN1, we do a MEN1 genetic analysis. If there is no MEN1 mutation identified, then we can keep the patient on surveillance for other MEN1 related tumors. If a MEN1 mutation is identified, then we genetically counsel all the first degree relatives, and then we do a mutation test for the first degree at-risk relatives. If they are negative for this particular mutation, then they do not need any further investigations. So in patients who have MEN1 mutation, they are continued to be kept on clinical, biochemical and radiological evaluation for MEN1 tumors, at which point they become abnormal, then they undergo further investigation and diagnostic testing. However, if during biochemical surveillance their biochemical markers are within normal range, then they just need to be kept on surveillance.